chairpersons and my dear friends, I have been asked to speak on percutaneous pulmonary valve implantation post Tetralogy of Fallot repair, planning and step-by-step. So in the interest of time, I'm just going to discuss only one of the subsets of tetralogy, and I'm going to only discuss one of the many valves available for taking care of this subset of patients. Some of you who are not really tuned to congenital hearts, these are some of the techniques used for repair of tetralogy. You can have a valve preserving surgery, you can have use of transannular patch, you can have use of right ventricle to pulmonary artery conduits, and in some of the patients who undergo a redo surgery for right ventricular volume overload following a transannular patch, they end up having a bioprosthetic valve. After Tetralogy of Fallot surgery, many of these patients, as a matter of fact, all of them, will have some form of RVOT dysfunction because surgery for tetralogy is purely palliative. And this dysfunction can be in the form of stenosis or in the form of regurgitation, and more often than not, combination of stenosis with regurgitation. Now let me concentrate only on this subset because this is by far the commonest subset, constituting maybe 80 to 85% of all operated tetralogy of Fallot. That is repair with a transannular patch. Most of these patients have a free pulmonary regurgitation and absence of pulmonary stenosis, and if it is present, it's just probably mild. These patients remain asymptomatic for a very long time, and that's why deciding the timing of intervention in these patients becomes so very crucial. Now coming to step by step. So these are some of the steps that I'm going to discuss in next 5 or 6 minutes. When to intervene, role of CT, baseline hemodynamics, baseline angiograms in the right ventricle and the main pulmonary artery, interrogation of the right ventricular outflow tract in the Cath lab, followed by coronary interrogation to be sure that they are not getting compressed or not expected to get compressed. Role of pre-stenting, as you know, some of them have already given up pre-stenting and would directly put in a valve, although we continue to pre-stent these massive native RVOTs, followed by valve deployment and post-deployment angiograms and medications. So let's begin by answering the first question, when to intervene. If the patient is symptomatic, obviously he has bought therapy for himself. In the absence of symptoms, I think MRI remains the gold standard in deciding the timing of intervention. Right ventricular end diastolic volume index of more than 160 ml per square meter or end systolic index of more than 80 ml per square meter, or pulmonary regurgitant fraction of more than 45% and right ventricular ejection fraction of less than 45%. Are some of the MRI criteria which decide the timing of intervention. And if the indication is soft and you're not sure whether you have to go in or not, it is better to take help of cardiopulmonary exercise test and use a VO2 max to decide the timing of intervention. Now, talking about the MRI, I think these are some of the pictures that you will see classically after transannular patch, a huge right ventricular volume overload, and you can see the right ventricular outflow tract. So MRI is basically useful to decide the timing and not really for planning the procedure. For planning the procedure, I think CT scan is probably the most important thing. It helps you in estimating the landing zone diameter, helps you in estimating the length of the landing zone, the presence, severity, and extent of calcification that helps you in deciding whether or not you're going to use a covered stent to protect right ventricular outflow tract from having any kind of accident following dilatation of calcific RVOT. And then, of course, relationship of the coronary arteries to the landing zone, because compressing a coronary artery can have real life-threatening implications. So CT scan is really helpful, and you can look at the measurements of the CT scan at the level of the annulus, and then you can look at it in the just above the annulus. You can see here somewhere after the sinuses of Valsalva, and then you can look at the measurements at various levels. Now, based on these measurements, you will decide as to what kind of balloon interrogation you are going to do in the Cath lab. So somewhere, if you have measurements anywhere between, say, 30 to 32, as was in this case, we decided that probably 32 millimeter balloon would be one of the balloons we would use to interrogate the right ventricular outflow tract in the Cath lab. As far as anesthesia access and hemodynamics are concerned, usually done in under general anesthesia, 2 femoral veins and 1 femoral artery, sometimes 3 femoral veins if you're going to do a rapid ventricular pacing. Start with baseline hemodynamics, the right atrial, right ventricular, and the pulmonary artery pressure, and the left ventricular end diastolic pressure, just to get an idea about the ventricular function. So these are the 2 most important angiograms. The first is in areocranial. You can see this here. And you can make some of the baseline measurements. In this particular case, the measurements were anywhere between 26 to 34 millimeters. And the most important measurement is at the level of the choke point. So here the choke point measurements were measuring around 29 millimeters and around 27 millimeters. The second important angiogram, which gives you a good idea about the landing zone and the right ventricular outflow tract lie, is the lateral projection. And here again, you can make some basic measurements so as to give you an idea as to what kind of balloon you are going to use to interrogate this right ventricular outflow tract. As a matter of fact, for such massive right ventricular outflow tract, most often self-expanding valves are used. Unfortunately, in India, we don't have access to self-expanding valves like Harmony or the Altera pre-stent or the Pulstar valve or the Venus P valve. Venus P valve is available, but very intermittently. It's not very regularly available. Having said that, with the advent of 32 millimeter and 35 millimeter balloon expandable valve from Merrill, the My valve, many of these patients, almost 80 to 85% of these patients can be tackled with balloon expandable valve, as we did in this particular case. So in the absence of a self-expanding valve, we decided that we would consider using a balloon expandable valve. So this is the balloon which is used to interrogate the right ventricular outflow tract, and you see that how beautifully it gets sealed. This is a 34 millimeter sizing balloon from Abbott, and you can see that at the level of the waist, it measured around 31 millimeters. And this is in lateral projection. Again, you can see it's a massive right ventricular outflow measuring somewhere in the vicinity of 32 millimeters. So it was decided that we would go ahead with a 35 millimeter My valve on a 35 millimeter navigator. Now, before we went on with the valve, because it is such a massive right ventricular outflow tract, it has been our practice to pre-stent these right ventricular outflow tracts. In order to pre-stent, we don't have a balloon which is 35 millimeters, so we use the same navigator balloon to pre-stent. And before using the navigator balloon, this is our own sheath called the Python BZ sheath, which can go on 2 or even 3 guide wires. In this case, we did not need one because the right ventricular outflow tract lie was pretty cool, and we were able to navigate across this right ventricular outflow tract even on a single wire. So once the 24 French sheath is there, then we went ahead with a Ziffer stent, which is a 36 millimeter Ziffer stent on a 35 millimeter navigator. You can see that we are trying to get the stent in position, and then you can see that we are doing a rapid ventricular pacing. This is the way where we are going to deploy our stent. These are the choke points here, one at the level of the annulus and one at the level of the sinotubular junction, just about the sinuses of Valsalva. And this is the actual deployment of the stent over navigator. You can see that the stent is getting deployed over 35 millimeter navigator. Once the stent is in position, then you can see that the proximal portion of the stent wasn't well inflated, so we brought the balloon back, and you can see that the stent was deployed. Once the stent is deployed, then you can see that we have made a right ventricular angiogram to show that the landing zone is well created. And then, of course, getting the 35 millimeter My valve across the landing zone over the wire was simple in this particular case, but sometimes can be tricky if there is a wire bias. Unfortunately, we couldn't record this particular deployment, but this is the valve deployed inside the landing zone here, 35 millimeter My valve, and that's the final angiogram showing no pulmonary regurgitation. Of course, there was no pulmonary stenosis in this case to begin with. So we got a pretty good result. So in conclusion, ladies and gentlemen, I think what is important in order to have a successful procedure is appropriate timing, precise patient selection, selecting the ideal device, the type of the valve and the size of the valve, proper planning, and perfect execution of the plan. Thanks for your patient hearing, ladies and gentlemen.
Sir, how often do you, yes, sir. Sir, excellent presentation, sir. How often do you see the requirement of broadening of more QRS complexes in such patients? Because we have learned traditionally, more the dilatation of RVOT tracts, there will be more QRS complexes, and later on they may land up into this thing. But how often do you see with implanting such a huge valve? And number two, sir, is a routine practice? Do you see guiding or probably diagnostics for coronaries to see the degree of impingement, or you go for a CT coronary angiography in such patients?
See, usually the first question is that almost all the patients of Tetralogy of Fallot will have widening of the QRS, and almost 90% of them will have a right bundle branch block. But as you very rightly said, that as the time progresses and RV gets more and more dilated, the QRS gets more and more broad. And as a matter of fact, it's one of the most important indicators of a sudden cardiac death. So it's a very important parameter that we continuously monitor. The second important thing is regarding the, what was your second question?
Coronaries, sir.
Coronaries. So although for a non-stenotic lesion, coronary compression is a rarity, to tell you the truth, because most of the valve will be inside the right ventricular outflow tract. The problem of coronaries is when you have a stenotic right ventricular outflow tract, maybe a native outflow tract or with a RVPA conduit. And the worst of the coronary compressions are with RVPA conduits, which are calcific. There is no way of exactly evaluating the coronaries, because if you try to evaluate the coronaries with a balloon to which you are going to take that particular conduit to, you may end up rupturing the conduit, which is as bad a complication. So most of the people nowadays put a covered stent at a much lower diameter. Say, if the conduit was 19 millimeters, now it is calcific around 14 millimeters, you put a 15 millimeter stent and then go millimeter by millimeter to see whether the coronaries are going to, or likely to get compressed. It is easily said than done, and believe me, that till such time you actually go to very close to the coronary, I think it's almost impossible. Many times you may put a stent and you may think that no, that's not the way to go, and you may have to actually back out. So the coronary compression is a very important issue in stenotic lesions, and family needs to be counseled very, very carefully in these cases.
So just lastly to ask one more, can you just brief us on your own invented BZ sheath, because it's a very, very important, we are using in and out right now, because 2-3 wires we can cross it across. So please put words on it, sir.
So basically, BZ, B stands for Bharat and Z stands for Ziad. We are the co-inventors of this sheath, and we were just given the US patent just a couple of months back. This has been designed by us, but manufactured by Merrill. And what it has done is that we can take up to 3 guide wires, put them in either one pulmonary artery or on either sides, depending upon where you want to put them. We have not studied it still in details as to whether putting on 2 sides will take away the wire bias or not. If you have 2 or 3 guide wires, then the trackability of this sheath, especially 18 French, 20 French, 22 French, becomes much easier as compared to over a single wire. And as you know, these right ventricular outflow tracts are massive, and the inflow and the outflow are at 90 degrees to each other. So trackability becomes better. Still, what we have not been able to conquer is the wire bias. So even if it tracks better, sometimes it keeps on abutting against the outer wall of the right ventricle. And so currently we are working on that as to how to get rid of this right ventricular outflow tract bias. We are planning to manufacture from 14 to 26 French. Currently available size is 24, and 14 is in the making.
Congratulations.
Thanks a lot, sir.
Thank you.